Hello, I'm Rob Diller with DocWire News. We're joined today by Dr. Deepak Bhatt, Executive Director of Interventional Cardiovascular Programs at Brigham and Women's Hospital, as well as Professor of Medicine at Harvard Medical School. Dr. Bhatt is the principal investigator of the REDUCE-IT study, as well as the senior author of the REDUCE-IT renal study, which he'll be discussing today. Dr. Bhatt, thank you very much for joining us today.
Yes, great to be here with you.
Okay, so talk to us a little bit about the REDUCE-IT cardiovascular outcome study, as well as the subgroup analysis, the REDUCE-IT renal study.
Absolutely. Maybe I'll just briefly recap what REDUCE-IT is overall, and then specifically we can chat about these analyses, which are based on the patient's baseline GFR. So what REDUCE-IT consists of is an over 8,000 patient trial. Patients were randomized to one of two arms to either receive EPA or icosapentaenoic acid in a highly purified prescription form known as icosapentaethyl, and patients received 4 grams of this per day, or were randomized to a matching placebo and were followed for an average of 4.9 years and a maximum of 6.2 years. These patients consisted of about 70% with secondary prevention type indications, people with coronary artery disease or cerebrovascular disease or peripheral artery disease, and about 30% were high-risk primary prevention. So they all had diabetes plus at least one additional cardiovascular risk factor. So that's the overall population, the randomization. Everybody was supposed to be on a statin. The LDL at baseline was supposed to be between 40 and 100, and the triglycerides were meant to be above 135 milligrams per deciliter. So high normal to somewhat elevated triglycerides was the major entry criteria into the trial. What the study found overall for the primary endpoint of cardiovascular death, MI, stroke, coronary revascularization, or unstable angina was a 25% relative and about a 5% absolute risk reduction that was highly statistically significant, worked out to a number needed to treat of only 21. So overall, the trial was very positive, robustly so. And even if one looked at the key secondary endpoint of cardiovascular death, MI, stroke, so-called heart events, there was a 26% relative risk reduction, again, highly statistically significant. So the overall trial results published in the New England Journal of Medicine, very positive, led to the FDA approval of this drug for this indication of use in patients such as the ones in REDUCE-IT just last December of 2019. So that's the overall trial results and what's happened in terms of regulatory approvals.
Okay, and did any of these findings surprise you at all?
Well, that's the overall trial results. What we presented now most recently at ASN was specifically REDUCE-IT renal. So what we did in this analysis was look at patients by their baseline eGFR in a pre-specified analysis. And the cut points were less than 60, 60 to 90, or greater than 90. And the bottom line is there was a consistent benefit across all these different groupings of GFR with no particular different safety profile in those patients at the lower GFR range versus in the higher GFR range. So as in the overall trial, the drug looked very good in terms of safety and very good in terms of efficacy in patients at the lower GFR range. We also examined in a post hoc analysis, not just those pre-specified GFR cutoffs I mentioned, but also going down to the 15 to 30 range, 30 to 45, 45 to 60, and greater than 60. And again, it was the same story with a consistency of benefit, including in those patients in the lowest GFR range. So what we've shown overtly now for the first time is that icosapentaethyl is safe in those patients with low GFR, and it's also efficacious. And as your audience knows quite well, patients with low GFR, those with substantial kidney disease, are at very high risk of ischemic events. But now, at least in those that have elevated triglycerides, we have an additional strategy to lower that risk.
And regarding the REDUCE-IT renal trial, were there any limitations that you want to report?
Well, just to make sure that your audience is aware, in the overall trial, as we found in these analyses, there was a slightly higher risk of atrial fibrillation in patients randomized to icosapentaethyl versus placebo, though in the overall trial, and even in the subgroup that developed atrial fibrillation, there were consistently lower rates of stroke, MI, cardiac arrest, sudden cardiac death, cardiovascular death. So Atrial fibrillation is something, of course, we would take seriously, especially those of us that are cardiologists. But to put it in context, the biggest risk of atrial fibrillation, what we fear, is stroke, and that wasn't increased in the trial. In fact, it was decreased. The other side effect to note, other than a higher risk of atrial fibrillation, is a higher risk of bleeding. Though fortunately, there was no significant excess in major bleeding. It was minor bleeding that was increased in the overall trial from about 10% to 12%. And those findings were consistent across GFR as well. So other than that, I would say really the things to be aware of from a physician's perspective, including nephrologists, is this is something that they need to think about in terms of globally reducing the risk of patients that they're seeing, in addition to other approaches such as blood pressure control in those with diabetes, glycemic control in those with dyslipidemia, LDL control. But now another risk factor to think of in those patients with kidney disease, which is elevated triglycerides, and the reduced renal analyses suggest that we can actually do something about that risk, that it's a modifiable risk. So that's an important message for all nephrologists, or for that matter, even primary care physicians, to be aware of.
Okay, and in the overall study, as well as the subgroup analysis, what would you say are some of the key takeaways, or the key takeaway, and the overall implications of the findings?
I think that's a good question. Really, the key takeaways, I think, include that, first of all, triglycerides have been in and they've been out, but they're in again. So it's important, first of all, to measure triglycerides, because that is what is the trigger for prescription of icosapent ethyl. And as I mentioned, in the overall REDUCE-IT trial, about 10% of the patients had quote unquote normal triglycerides. That is, triglyceride levels at baseline less than 150. So it doesn't actually appear that the benefit of the drug is contingent on the triglycerides being elevated, but that's what we studied. And in the US, the labeling does say that the patients have to have triglycerides greater than or equal to 150. It doesn't specify whether that's fasting or not fasting, but it does say that those triglycerides are the trigger for therapy, even though in the trial, by protocol, we'd allow triglycerides greater than 135. And as I said, about 10% ended up having normal triglycerides. So message number one is pay attention to the triglycerides. Message number two is if they're elevated, do all the right things in terms of dietary counseling, exercise, weight loss, and so forth, and in appropriate patient statin therapy. But if that doesn't do the trick, then icosapent ethyl is something to consider.
And lastly, Dr. Bhatt, anything else to add?
I think that it's important for all physicians, including your audience, nephrologists, to keep an eye on this field of omega-3 fatty acids. I think there's a lot of interesting research going on. There's going to be research that will be presented at the American Heart Association, other smaller meetings in November and December, having to do with EPA, or icosapent acid. That's an omega-3 fatty acid. That's the active ingredient in icosapent ethyl, which is a highly purified ethyl ester prescription form of EPA. Lots of good basic science that's coming out. And a question nephrologists often ask is, what about effects specifically on the kidney? And in REDUCE-IT, we didn't see any benefit or harm on GFR per se, but future studies will have to really nail down whether there's a potential for this approach to actually improve renal outcomes. Our study wasn't really designed specifically to look at renal outcomes, such as microalbuminuria or macroalbuminuria, but future studies really should address this, because there's the potential for this class of drugs to favorably affect even renal specific endpoints. Having said that, even if we don't know what the effects might be on those types of renal endpoints, the fact that icosapent ethyl reduces important cardiovascular events, including death from cardiovascular causes, is reason enough to prescribe it in appropriate patients.
Well, that was Dr. Deepak Bhatt. Dr. Bhatt, we thank you very much for your time today.
Yes, great to be with you. Thank you so much.
All right. Stay safe, sir. Have a great day.
You as well. Bye now.